Hi, my name is Anne Peralta, and I'm going to talk about early versus late parenteral nutrition in critical ill children. First, we have critical ill children cannot normally be fed by mouth, and as a result of pronounced macronutrient deficit often develops after a few days. This macronutrient deficit has been associated with infections, weakness, prolonged mechanical ventilation, and delayed recovery. In order to prevent or limit the development of this macronutrient deficit, current guidelines, which are based largely on small studies with surrogate endpoints and on expert opinion, advise care providers to initiate nutritional support soon after a child's admission to the pediatric intensive care unit, or also is known as ICU. We also have a video that we're going to see now.
Hi, I'm Chris, and my son was previously a patient at Children's Hospital of Pittsburgh, WPNC's caregiving. I was sitting practically where you are right now. It's human nature to worry anytime your child is in the hospital, but especially when they pick you. As it's called here at Children's Hospital. For most of us, this is a very unfamiliar place. And for the next few minutes, members of the PICU staff and I want to take the mystery away from your surroundings. Once you're more at ease, you will be better prepared to help your child in his or her journey to wellness. The PICU is a unit in the hospital for infants, children, and teens who require intensive nursing care and monitoring. To enter this unit or receive information by telephone, parents and guardians need a confidentiality code that is assigned specifically to your child. Your child's nurse or the unit's health coordinator who is located in the entrance of the unit will give you this number. Please.
Okay, next one we are going to continue, and we have the preferred route for the administration of nutritional support in the pediatric ICU is the nasogastric tube, but enteral nutrition is often delayed or interrupted. Since nutrition should equal basic metabolic needs and in children should allow for growth, children require relatively more macronutrients than adults. Hence, the current standard of pediatric intensive care is to meet these requirements early. When enteral nutrition fails, parenteral nutrition is advised, but current nutritional practices in pediatric ECUs vary owing to concerns about the overdosing of parenteral nutrition. First, there is a dearth of adequately powered randomized controlled trials that address the effects of parenteral nutrition on clinical outcomes in critically children. With respect to critically ill adults, recent large randomized controlled trials have questioned the benefit of early parenteral nutrition. With now the other video we're going to see now.
After a few days of critical illness, children develop profound macronutrient deficiency, which may be associated with infections, delayed recovery, and prolonged mechanical ventilation. Enteral nutrition is the preferred method of meeting the macronutrient requirement. If enteral feeding is not possible, however, or fails, parenteral nutrition is advised. But evidence to support the timing and benefit of parenteral nutrition in critically ill children is lacking. In a multi-center study, 1,440 critically ill children from newborn to 17 years old, with 45% under 1 year old, who were admitted to the pediatric intensive care unit and at risk for malnutrition, were randomly assigned to either early or late parenteral nutrition. Early enteral nutrition was attempted in all patients, and they all received intravenous micronutrients and a similar volume of fluid. Analyses of the co-primary outcomes demonstrated that patients who received late parenteral nutrition were less likely to acquire new infections while in the intensive care unit, and needed intensive care for less time. The mortality rates across predefined time periods did not differ significantly between groups. There were significantly more hypoglycemic events in the patients in the late parenteral nutrition group. Thus, withholding parenteral nutrition for 1 week in critically ill children in the pediatric intensive care unit, as compared with initiating early parenteral nutrition, is clinically superior, with fewer new infections and a shorter stay in the intensive care unit. Full trial results are available at nejm.org.
Okay, and then the next video that we haven't seen, we're going to see it now. No, better if we continue. Therefore, is this international multi-center randomized controlled trial we investigated whether a strategy of withholding parenteral nutrition up to date 8 late parenteral nutrition in the pediatric ICU is clinically superior to the current practice of early parenteral nutrition. The results of our trial show that withholding parenteral nutrition for 1 week in the pediatric ICU was clinically superior to providing early parenteral nutrition. Late parenteral nutrition resulted in fewer new infections, a shorter duration of dependency on intensive care, and a shorter hospital stay. The clinical superiority of late parenteral nutrition was shown irrespective of diagnosis, severity of illness, risk of malnutrition, or age of the child. The observation that critically ill children are at the highest risk of malnutrition benefit the most from the withholding of early parenteral nutrition was unexpected. However, this finding was reinforced by the apparently greater benefit of the strategy for critical ill-term neonates than for older children, in that immediate initiation of nutrition is currently advised for neonates because they are considered to have the lower metabolic reserves. Now the other video that we haven't seen, and we're going to see it now, is this one. What is enteral feeding tube?
Let's start with the question that most people have. What is an enteral feeding tube? An enteral feeding tube allows liquid food to enter your stomach or intestine through a soft, flexible tube. A tube inserted in the stomach is called a gastrostomy or G-tube. A tube inserted in the stomach but ends in the small intestine is called a jejunostomy or J-tube. The site on the abdomen where the tube is inserted is called the stoma. The location of the stoma depends on your specific operation and the shape of your abdomen. Most stomas lie flat against your body and are round in shape. Conditions such as cancer, trauma, nervous system, and digestive system disorders can affect your ability to eat and require a feeding tube either temporarily or permanently. Let's review your digestive system so you understand a little more about the feeding tube. When food enters the mouth, the lips and tongue move it toward the back of the throat. Food moves into the esophagus and into the stomach. The opening at the top of the esophagus tightens to keep food from entering the airway or trachea. Food travels from the stomach into the small intestine, where enzymes break down food into thick liquid. The liquid then passes through the large intestine or colon and eventually moves out through the rectum. Most gastrostomy tubes have an anchoring device on the inside of the stomach and an external device. This secures the tube in the stomach. A percutaneous gastrostomy tube, PEG, or percutaneous gastroduodenostomy tube.
And now we're going to continue because we don't have a lot of time.
With a
And
device on the inside of the stomach. A PEG tube or PEG button may be a short or a long tube that extends out of the stoma about 12 inches.
okay, late parenteral nutrition result is higher plasma bilirubin levels than did early parenteral nutrition in these critical ill children, as it has in adults patients, which provides further support for the concept that increasing in plasma bilirubin levels in response to critical illness may be partially adaptive. In conclusion, in critical ill children, withholding a parenteral nutrition for 1 week while administering macronutrients intravenously was clinically superior to providing early parenteral nutrition to supplement insufficient enteral nutrition. Thanks for watching and have a nice day. Bye.